questions, and please ask questions in the chat room. This is for you. This is for exchange of information. And I certainly go by the rubric that you don't know what you don't know. So Thane is on the call. Thane Peterson started, what, 2.5 weeks ago, Thane?
It's actually just been over a month.
Seems like yesterday. So Thane comes to us most recently from Indiana. He's took over Doug Skinard's position as Vice Dean of Finance and Administration and Associate Vice President for Finance and Administration for the Office of Health Affairs. And he's gone up to speed extraordinarily quickly. I often say, and I believe this in 100% of my being, that we are the most complicated medical school in the country. And Thane's position is a very, very important one. As we'll speak about today, I think we've made tremendous progress towards financial stability and are nearly at the point where we'll be start to do some investments and resources. I also want to announce that Ann Messman, for about 2 months now, maybe even 3, is the new Associate Dean for Graduate Medical Education and the Wayne State Designated Institutional Officer. And I don't think I ever officially introduced Karen Morzikos, who came here in November already, not quite a year, but getting close to it, as the Executive Vice Dean. When I was recruited, this was one of the discussions that Roy had with me due to the complexity of the medical school. He had concerns, as well as myself, that you just, the inability to focus on all the issues. And one of the more pressing issues Karen has been focusing on is our searches. So she is taking an administrative role in all the searches along with Janice. And we have 2 finished searches already. That was Anne and Maria. We have 3 chair searches, I think, and 2 vice dean searches ongoing. And as we close each one, we're going to open up a new one. And my goal, which may not be realistic, but it is my goal, is to have all the searches done by the end of the year. We've had a pretty successful year, all things considered. I give the faculty tremendous credit for handling all the exigencies that happened with COVID, delivering a very effective medical education in a trying environment. And unfortunately, going back to Scott Hall is also a trying environment. We all know the issues with Scott Hall, and we'll talk about the plans to replace that. But, you know, we've had a good year. I think you all deserve kudos for that, to the man and to the woman. And I just want to bring up a few highlights. Our U.S. News and World Report for Research has us now ranked at 66. We were 71 the year before, which for U.S.
They
News and World
didn't know what to do.
Oh, okay.
You did what? Yeah.
I'm not sure if people can mute themselves before asking a question. So going up by 5 ranks in U.S. News and World Report in 1 year is quite extraordinary. The AAMC ranked us as the 26th most diverse medical school, and most of the top 10 are HBCUs. And based upon our admission statistics for the class about to start, I think we're going to be maybe even break the 20th barrier. So that's part of Wayne State's historical mission. It's, I think, part of why we're all here. And it's something that we should take justifiable pride in. NIH funding is up about 7.5% in the last 5 years. And we're ranked again roughly 70 plus 77 for NIH funding. Unfortunately, that doesn't include the PRB, because the PRB expenses are considered contractual revenue. If you put them in, I think we would be in the low 60s. We just graduated 104 masters and PhD students. There were questions about that, but that's an important part of our mission. Our mission is number 1, 2, and 3 to educate, and educate not just medical students, but master's students, PhD students, genetic students, and residents. We have basically nearly 100% student completion of both doses of vaccine. We don't ask faculty for obvious reasons, but I assume it's pretty close to that. You know, Wayne Health is a separate entity than the School of Medicine, separate financially, separate administratively, and separate legally. But many of the faculty work in both institutions. And I think we should take pride in some of the initiatives Wayne Health has done over this past year under Chuck Shanley and Phil Levy's leadership in terms of testing in the communities, providing vaccines in the communities. As these are faculty members, is something that you should take pride in. And the pediatrics program under Herman Gray's leadership has really blossomed into a full-fledged, not even small, moderate sized at this point, pediatrics department. As many of you know, there were issues with University Pediatrics and Children's Hospital that created an untenable situation. And we were left as probably the only major medical school in the country without a pediatrics residency, and the only major pediatric group without a landing pad to place their patients when they got sick enough to be hospitalized. So we negotiated with St. John's at the edge of Detroit, which actually has an accredited pediatric hospital within a hospital. And St. John's and their residency are now the official pediatric programs of Wayne State. So as of July 1st, we have a pediatrics residency again, and we have an even larger pediatric department than we had. And I believe in just a few years, it'll be a viable competitor to both Children's Hospital and University Pediatrics. We have several new clinical training sites, and probably the prominent ones would be Trinity, St. Joe's, and St. Mary's in Pontiac and Livonia, respectively, and Michigan Health Professionals, MHP. It's created elasticity on our training opportunities for medical students, nursing students, PA students, all the health profession students. And as we'll talk about later, also provides some elasticity to our budget. We just got some of the numbers this morning. Those are vital funds that we need to be able to continue the mission that we all want to continue. To me, our laser focus in the next 18 months is on the LCME visit. And there's probably a dozen things that the staff and myself are aware of that are potential LCME issues. And there's another 60 things that we're not aware are LCME issues, but are there. So the best we can do is work on the LCME issues that we're aware of. The leading ones are the physical plant, recreation space for students, eating space for students, diversity of faculty. Fourth one would be chairs openings. And those would be the major ones that we're focused on. And I can talk about how we're addressing all of them. I've spoken a little bit about it already. But we're also making strategic investments unrelated to the LCMA. Dan Walls put in an MSTP application just a few weeks ago. And that's a strong investment in our future as a PhD granting institution. We have a large investment in that program, and the president has given us additional investments for that program. So to me, that's an important commitment for one of the major purposes of a leading medical school, which is to create the next generation of scientists, in this case, physician scientists. We're about to submit a shared instrumentation grant for a new MRI. Steve Lanier Shop just recently was granted a shared instrumentation grant. We got a renewal of Joe Dunbar's, I think, over 20-year-old grant for greater access for underrepresented in graduate programs, another commitment of the institution to PhD training. And the last thing is there's a strategic planning process ongoing. Per LCME requirements, the school is required to have a strategic plan. The president and myself have decided that the school management strategic plan will be an offshoot of the university strategic plan. That planning is in full force. And in fact, I had an hour meeting with one of the strategic planners just this week about my thoughts on that. But we've had, under the circumstances, I think, an exceptional year. And you know, I'm a radiologist, as many of you know, and I ran a radiology department, and 80% of my job was complaints. The ICU patients didn't get their chest x-rays done on time. This CAT scan read a uterus in a male patient. This CAT scan missed a ureteral stone and what have you. And every once in a while, rarely, but once in a while, we would get a compliment. And I would savor the compliment just because there were just so many times that we got complaints. And I don't think and I fault myself, compliment the staff enough. We all have a tendency to see things that are wrong, but not things that are right. And we spent this last year providing a medical education to master's students, PhD students, and MD students in the most adverse circumstances that probably any of us will have in our lives or our careers. And those students, I think, graduated not only the same as any other student, but in my personal belief, in all sincerity, is better than other students. And that's a testament to our faculty, to our staff, and most importantly, to our sense of mission. The belief, I think, that everyone who works in Wayne State has, that they're here for a reason, and that reason is not a job. That reason is a purpose, a raison d'etre. And I think we fulfilled that raison d'etre extraordinarily well. And I have no doubt that we'll continue to fulfill our mission, no matter what the circumstances are. But let's now try and get to the questions. A bunch of questions were submitted in advance. Let me start out with the campus restart. And just a few things about that. So the first thing is that safety for faculty, students, and staff is of paramount importance. The second thing is that the medical school, in terms of adapting to a disease, should be a leader. The third thing is that we're temporarily a leader because our fall semester starts roughly 2 months before all the other fall semesters. So in 2 short weeks, our freshman equivalent class is coming in, when for the rest of Wayne State, their freshman equivalent class comes in at the end of August. So we have less time for which to adapt, but we're going to have an adaptation where we'll have 4 phases. The first phase is ongoing. It has to do with the restart committee. It has to do with ensuring that people are properly trained, facilities are properly cleaned, and that we have the plan for how to progress in terms of faculty and staff returning to campus. Starting July 6th, we'll have limited return to campus coverage, about 25%. And that will be based upon the managers and the supervisors for specific areas, but with the assumption that student-facing staff And obviously faculty should be the first ones coming back. August 2nd, roughly a month later, we'll be at the halfway point. And then August 23rd, we should have 100% of our faculty and staff on site. Now, some individuals may have specific reasons why this may be difficult or put themselves in jeopardy or in danger. And at that point, they should discuss those with human resources and to see what accommodations might be able to be made for them. Now, this is a form, it's a little bit speedier than the rest of the campus, not much, a little bit, but I think that fulfills the leadership mission I think that you all believe in. But secondarily, we adapted on a dime, basically, from one day being on campus to the next day being completely off campus. And that ability to adapt and be facile is a skill that I think we have as an institution. In terms of practice, residencies swoon over Wayne State students. They all want Wayne State students to be residents in their program. Now, why do they want Wayne State students? Because for 153 years, they've rolled up the sleeves and got the job done, and they've been adaptable. They've been able to handle stress. They've been able to perform their tasks under adversarial conditions. And I think they learned that from you. And that's what makes Wayne, Wayne. And that's what makes you, you. And that's characteristics that you sublimate into the students. And that what makes the students desirable. So I know this is a stressor. I understand that. And my foremost priority is not to put anyone at risk. But the second priority is to make sure we give the optimal education that we can. Okay, now let's get to the questions. First question was about CDC guidelines to drop the mask requirement. What I believe we will do is sometime over the summer, we're going to take a survey to see the percentage of faculty and staff that are vaccinated. And although herd immunity is a moving target, but when we have a percentage from that survey that's recognized as being juxta herd immunity, then likely we will then minimize the use of masks and social distancing. We will not require for the time being documentation of COVID-19 status, so any survey will be done anonymously. Related to several things, but most importantly, because the vaccines are under emergency use authorization, which is different than a flu vaccine, which goes through routine channels. Waiver, exemption, and exclusion status for the non-vaccinated, that will be at the human resources discretion. But as the fall progresses, I think it'll be increasingly difficult everywhere in the campus for there to be waivers. We'll be allowed to split our time between in-work offices and in-home offices. Well, during this transition period in the summer, you can. And in the fall, it'll be likely a minority of staff and certainly a minority of time. But that would be a supervisor decision in consultation with human resources. A question about comfortable physically going back to the office. To be frank, I think I used to work in Canada, and there was a private practice group, and then we had our academic group, and the private practice group would dump all the difficult cases that took a lot of time and they got very little money for on the academic group. And their argument was always, I'm not comfortable reading this case. So when you enter a job, you have a contract with your employer. And with that contract, you provide services to the employer, and the employer provides payment and fringe benefits to you. And that employer may ask you to do things that you're uncomfortable doing. Certainly my employer does sometimes, and all my jobs I've had. But if it doesn't put you in what's generally recognized as danger, I think comfort, if I'm going to be overly frank, and I always am, has not much to do with that. M2 students ever going to see the inside of a lecture hall again? Well, starting in July, they will. Some of the lectures are going to be remote. In fact, we had many, many remote lectures even before the pandemic started. But certainly students will be able to see the inside of a lecture hall socially distanced with masks starting sometime over the summer. Scott Hall gym reopen. I think gym should be in quotes. We're trying to get a better gym for Scott Hall. Again, we follow the campus policies. When the regular campus gym opens, which I think is already opened, we should open ours shortly thereafter. M1s will have in-person events. They're going to have small group educational sentences, continuity clinic sessions, anatomy sessions. So there'll certainly be a fair amount of in-person content beginning July 9th. Student groups can hold in-person events following the Public Health Committee guidelines. And the summer that should be easy because anything done outdoors has no guidelines. You can do whatever you want outdoors. Questions about diversity and inclusion. So we have a very active search committee on for the leadership of the Diversity and Inclusion Office in the School of Medicine. And since this is so important for our mission, I asked them not only to do a search, but to think about what resources that office needs, what organization that office should have, and to think about best practices. Because our goal is to enhance and notably enhance that. So they've met, I believe, more than half a dozen times at this time. They've come up with concepts for organization. They came up with a leadership job description. That leadership has been posted, and we already have at least one applicant for it, and I assume there'll be many more. In addition, we're finalists for DeAndrea's replacement. They're down to a few finalists, and a decision will be made about that. Probably.
You must come out with DeAndrea.
I'm not sure if is that to me. Okay. Will Scott Hall be properly cleaned? I'll ask Janice to look into that. Scott Hall is difficult. I've said it before, and I'll say it many, many times. You deserve better. I'm working hard to get you better. But certainly you deserve it to be as clean and to make you as safe as possible. So yes, we'll work on that. In terms of the new research building, I'm meeting, well, we don't call it a research building. The goal is to have two adjacent buildings, one to mimic Scott Hall, which is a combination of educational and research space, and one to be cancer research, and to have a common lobby and common basement with shared facilities between those two buildings. We have ideas for locations. Nothing has been finalized at this point. But I had conversations just this morning about creating a mock-up to be able to show potential donors. And we certainly have two donors that are progressing along at a predictable and a cautiously optimistic fashion to be able to pay for a reasonable portion of each of those buildings. What measures to ensure diversity in faculty and staff? So I've been here for about 1.5 years at this point. We currently have roughly half of our chairs are, less than half, probably 1/3 of our chairs are Anglo men and 2/3 are various underrepresented medicine, which I would say is among the most diverse leadership of any medical school in the country. Where I came from, which is not a model by any means, it's a negative model, there was a single chair that wasn't a white male. That was it. So we have 4 African-American chairs, we have 2 female chairs, we have, I believe, 3 chairs of Middle Eastern extraction, we have 3 chairs of East Asian extraction. Could we do better? Yes. Should we do better? Yes. But in terms of the leadership at the chair level, it's quite good. The leadership at the dean's level, We've tried to diversify the gender leadership. So the executive vice dean is now a woman. The dean for graduate medical education is a woman. The associate dean for continuing faculty education is now a woman. We have a ways to go, but it's a conscious effort and it's an important part of our mission. But more importantly, it makes us better as a school. There is an enormous quantum of literature that says diverse workforces perform better. Diverse corporate boards have better profits than less diverse corporate boards. It should be done because it's right, but more importantly, it should be done because it'll make us a better medical school. There's a question about transparency in the promotion and tenure process for young faculty. I don't think Bassem is on the call. Is Bassem on the call?
Yes, I am.
Do you want to take that, Bassem, please?
Yes, I do. So I'm going to start by the take-home message, which is the processes for promotion and tenure are faculty-driven processes. These are not administration-driven processes. So I'm not sure what the individual is asking is really trying to find out. But let me take you through the process so that you understand it.
Bassem, if I can talk, sometimes faculty members want like a cheat sheet of X amount of papers. This, what are the ballpark requirements for each level? That may be what the question they're asking.
Yeah, I think the factors have changed over time so that it's not really easy to come up with simple metrics. And it's really looking at the overall output of the faculty member that determines whether or not the process is going to be successful. So there is no time limit, minimum time and rank that is required before you can apply for promotion. There is no set number of publications that's required. What's required is evidence of excellence. And depending on the track, excellence in teaching is required of everybody. Excellence in scholarship and service is required depending on what other tracks you are in. But the important thing, which I really want people to remember, is that this is faculty driven at every step, and there are 3 steps. At every step, it is your peers who review your credentials based on factors that are really developed by the faculty themselves. It's not the administration that creates the factors. It's not the administration that reviews the credentials. And moving from one step to the next is entirely dependent on what happens at the previous step. So in your department, a committee of your peers is going to review your credentials and make recommendations to the dean. And usually what happens is that the dean, in almost all situations, would agree. If he disagrees, or even if he agrees, the decision moves up to the next level, which is the level of the promotion and tenure committee of the School of Medicine, which is also comprised of your own peers who look at your credentials based on the factors that you have created. So I'm not sure what the transparency question is, and I would encourage anybody who has any concerns or questions to call me directly. But in general, it is a process that is entirely faculty driven.
Okay, thank you, Bassem. So Bassem Dabaya is the Vice Dean for Academic Affairs, am I correct?
Faculty Affairs.
Faculty Affairs, of course I'm incorrect. Let me just get through some of the questions in the chat. Does Wayne have any future planning for having his own hospital for clinical care? This may change, but not as of now. I think we're too large a medical school to be dependent on any one hospital, number one. Number two is it's a tremendous financial risk to have a hospital. There's a lot of upside, but there's a lot of potential downside. And number three, we just do not have the reserves to be able to do a purchase such as that. Now, we do have contingency plans depending on what tenant may or may not do with the DMC. But the likelihood of us owning a hospital, although it would make my job easier, I think is more risky than it's worth. If people have offices that need cleaning, send it to Janice and she'll pass that on to Krista to make sure you deserve a clean office at a bare minimum. Let me just see what the other questions in the chat are. Okay, I'll go back to the other questions. There will be 2 white coat ceremonies, one for those who missed the last year and one for the incoming first year medical students. They will be done in person as part of this transition to campus. So budget deficit, we've gone a long way towards correcting the budget deficit. I would say we're about 75% there through decreasing administrative expenses, reorganizing how clinical faculty are paid. We're about 3/4 of the way there, in my opinion. So I believe within a year and a half, we should have a close to balanced budget. We're having increased PPEP funds coming in. I've been very, very aggressive about that. And that gives us, we cannot use those for ongoing expenses, and they must be used for expenses related to Medicaid services towards patients. But it does provide a cushion for certain areas of the shortfall that can be legitimately considered Medicaid expenses. And we've been aggressive and successful at that. But at the same time, we have this added stress of increased numbers of clinical sites, partially related to the Michigan State Henry Ford deal that we spoke about in the last town hall meeting. But I think the school is on a trajectory to be quite, not to be quite, but to be financially stable as any other medical school is in maybe a year and a half. We're not quite there yet, but I think we're getting there. And then on an ongoing basis, we would like to recruit new faculty. So we will be doing shortly a formal search for a chair of physiology with resources attached to that. We have an ongoing search for a chair of OB, GYN, with resources attached to that. And we're progressing with other chairs that are less smaller departments, less complex departments that have less resources attached to them. But I think we've had a great year. I think we're progressing on a really strong trajectory. We're getting recognized through grants for the AAMC, for the AMA. We're increasingly recognized for our diversity. And again, grants from the AAMC and the AMA for that. The 3-year medical school program, we should be able to start with the incoming class next year. We should be able to have 4-year dual degree programs with the class starting next year. And that 3-year program will have guaranteed residencies. The pediatrics department is progressing excellently. And I think a lot of the new clinical sites are really rounding out our educational mission that we're providing. And I think continuing the tradition that's always been Wayne State of serving the underserved and having students play a very active role in treatment. Now, this last question, I just did not understand about charging students for clinical teaching hours. If that person wants to elaborate on that verbally, I don't understand that question. And let me see if anything came up in the chat in between all this. I don't see any specific questions from me. So people are welcome to ask questions now in the chat.
So there is a question, what is the status of rebuilding the neurosurgery department? Who is the chair of it?
So there's a search committee. They've interviewed 4 finalists. They have 2 more finalists to interview. Those last 2 will be interviewed the second week of July. I have a meeting with the search committee, I believe it's July 19th. My normal way I work search committees is I'd like 3 recommendations unranked, but with people providing, with the committee providing positives and negatives. We have an agreement with the DMC to restart the neurosurgical residency. And once we select someone from our end, we'll try and get DMC buy-in for them to select them on their end and for them to then go about starting a neurosurgical residency. And again, we are a major medical school. I don't want to be pejorative against Michigan State, but I will be. And they're not a major medical school. Oakland is not a major medical school. And to be a major medical school, you need all kinds of residencies and neurosurgery among them. So it is important and will be prioritized to some degree.
I think there was one question on the list that came in that you may not have addressed. It's the, in regards to research, many Wayne State University School of Medicine research labs are top heavy with few research staff and limited admin support. What are your top 5 priorities to strengthen institutional support for basic research in the School of Medicine?
So the institution needs to provide the environment for research to thrive and progress, but not to provide ongoing research, ongoing resources, for instance, for research to thrive and progress. And part, we've had any number of reasons why we got into financial difficulty. But among those reasons was the act that the school should be paying for people's research. Now, I believe we need viable PhD programs, and I believe we need viable and strong PhD programs in every basic science specialty. And I am supportive of that. But those basic science PhD programs should not rely upon the school to support all 4 years of the student's training. And that doesn't occur in any medical school in the country that I've ever heard of. So I will do my part. I will recruit good chairs. I will give the chairs some packages. But our faculty also needs to do their part to put their salaries on grants and their students on grants. And I know it's an unpleasant topic of discussion, but I am always honest. And the school's mission is not to subsidize any individual person's research. That's one of the events, there were probably 5, that put us into financial difficulty. Will step 1 statistics be released? So step 1 is going to be pass-fail. I don't know if there's going to be any statistics available for the school. So to be honest, I just don't know the number. Someone asked as of July 6th. So for July 6th, 25% of the staff, and those are the patient-facing or student-facing staff, needs to be here. And the offices that service students should be staffed at all times. That is up to the supervisor to determine how best to do that. In terms of journal club sessions, if you socially distance them, certainly you can have journal club, I think, and you do the campus screener. Crediting clinical faculty for the time they spend teaching medical students. I think each individual faculty member should keep that log to some degree themselves. And there's 2 separate types of interactions with students and not just medical students. It's indirect teaching and direct teaching. And I would separate the 2. So direct teaching is outside the patient care experience, whether it be a small conference room, a group session, or a lecture. Patient care teaching is different than that, and I would quantify them both. Okay, so Margaret answered. I thought, Margaret, it was pass fail for the students taking it next year. Is that not correct?
It's for 2024 is the first year. It's going to be pass fail. So it's for, yeah, so we do have statistics for class of 2023, which should be coming out soon.
Oh, for the class of, I was thinking the date. Okay,
Yeah,
that's the
yeah.
misunderstanding.
Calendar date 2024, it'll go past fail. Yep.
Okay, other questions? It's always this unpleasant pause. You can say them verbally if you want. Again, encourage any question. I think you deserve answers to concerns you have.
So I'll ask a question.
Yes, who is I?
Rodrigo Andrade, pharmacology.
Okay.
I don't take graduate students, so this question doesn't apply to me, but I'm just curious. So historically, the reason why it has been difficult to implement paying graduate students on grants is that you basically select a graduate student about 2.5 years before it gets to join the lab. And historically, grants very seldom are for more than 4 or 5 years.
Mhm.
So that runs into a problem. And historically, the role of this, in principle, the role of the school has been to sort of serve as a buffer. Now, it hasn't always been implemented that way, but that at least was the theory. I wonder how you're going to finagle through this sort of timing issue.
Well, what I would ask back to you, how do the other 153 students manage, 53 schools manage to do that?
They're wealthy.
All 150? So,
The ones that have robust graduate programs, yeah, sure.
so again, I have an N of 4. So where I came from as the chair of radiology, if I had a graduate student, I had 17 graduates, 17 PhD students. I was required to sign a form saying that after year 1, I'm responsible for their funding, period. And either I have enough grants in the pipeline that I'm confident that I can fund them, or I'm not. But if I wasn't confident, then I didn't have the graduate students.
Okay, I'm just curious. I said I wouldn't take graduate students, so it's
But
not
that's
particular
how-
to me. But that is a problem that you will find a lot of. I'm just verbalizing what is a concern of a lot of the basic faculty, science faculty who get PhD students.
Yeah, I'm glad you asked the question, but I do think, we have to start being like other medical schools. And that's how other medical schools do this. So 2 questions or 3 questions. Support for research for the School of Medicine. So we're supporting the MSTP program. We're supporting shared instrumentation grants. We're ensuring that every department has some PhD students at all times, regardless of their grant status. We provide the tenure levels for all the faculty. That's far more support, again, than 153 medical schools do in this country. Now, it's incumbent upon the faculty to get grants, that this is the way schools work. And to put salaries on grants, and to put students on grants, and to put some equipment on grants. And we need to transition to that. So a question about Ford. Ford is not going to be lost as a clinical site. Ford is going to be either the second or equal to DMC as a number of clinical rotations. There'll be less than there are now, but not enormously less. They believe strongly in the need to have a relationship with Wayne State. Their faculty will continue, new faculty will get appointments at Wayne State. They'll get their promotions through Wayne State. We just signed another contract with them about finances that's favorable to the medical school. And so I don't think any student has to be worried about Ford not only not being available for rotations, but not being available on a large scale for rotations. The parking garages will open up by our beginning of back to the university. So in early July, the parking structures will be opened up. A question about 400 Max. So the university now owns 400 Max, so it's official university property. There is increasing clinical activity there. We are just finishing up the Horizons pediatric aid space, and we're finishing up construction on the second half of the second floor. So that is going, it's already a viable clinical rotation site. We have nursing students there. We have a teaching pharmacy there, the first teaching pharmacy in a multi-specialty group in the United States. We have PA students there, obviously medical students and residents. Looking at putting an interventional suite in there to start doing some procedures. So medical education is increasingly outpatient, and that's a really good site for outpatient education and clinical service, and right in the bullseye of our mission. If you look at the socioeconomic distribution of patients, those are the patients that we've always treated and we should be treating. Keep the questions coming. Suture rotations in Children's Hospital and DMC. Children's Hospital will have the same number of rotations we had this year and last year. We've changed pediatrics to do 50% outpatient. Although Children's was the index event that led us to that, I'm 1,000% sure that makes for better medical education. Pediatrics, for people who aren't going to be pediatricians, and even for most of those who will be, it's much more important to learn outpatient pediatrics than inpatient pediatrics when compared to surgery or OBGYN or neurology. And so I think having half of pediatrics being outpatient makes the educational experience better. Okay, I'm trying to read these. Bridge funding for salary support for productive grant applying non-tenured research faculty. I have never denied that. I believe the OVPR denies that, and that's a question for Dr. Lanier. I would be supportive of some bridge funding for that, but that the bridge funding comes from the research office, not from the School of Medicine. Keep them coming. Janice, did I miss any? With the increased emphasis on RVU production, so all medical schools have gone this way. It's not only not unique to Wayne State, it's the way every single medical school is. I would meet with my faculty twice a year. I would go through their RVUs and I would tell them their percentile. And I did that every year. And I was in another academic department. And my job before that, we did that. And my job before that, we did that. So this has been going on in most places for 20 years. There's the old joke, what do you do when there's a nuclear war? Anyone? Move to Buffalo, everything happens 20 years later there.
You're welcome.
So in terms of RVUs, we're 20 years out of date. Every other institution has been doing this for 2 decades. And they've managed to finesse balancing research, education, and clinical productivity. And it is a shock to the system. It's something different, but it's the way all schools work today, and we can't. And we can't keep on thinking that we're different, because if we're different in everything, then we're eventually going to fail. For the M1 class, we're shooting for a class of a little bit north of 300. I think we're at 305, 306. Medical school communications, we do an abysmal job on medical school communications. And thank God we have Susan, who joined us just about a year ago. So we're going to try and make a single medical school communication every day. No more than one, everything in that one communication, because Andrew's exactly right. Among the 100 things we do wrong, communications is up there. I've seen COVID patients as students in a hospital. I don't believe we have any school limitations on seeing COVID patients, and I don't believe any of the hospitals have limitations on students seeing COVID patients. DMC required proof of vaccination for the other health profession students. Maybe Margaret goes, but I'm not aware of them requiring it for medical students yet, but pretty much everyone is vaccinated. There's a question about the RAS office and it disrupting the ability to submit and manage grants. Let's take that offline because it's too complicated. But I'll just give you just a few ground rules. We inherited a huge budget deficit. And one way we're trying to address the budget deficit is by decreasing administrative costs. And when you decrease administrative costs, administration does things. It's not like it doesn't exist, right? You get health insurance through administration. Your checks come through administration. And as much as Charlie says to you that administration doesn't do anything, it's what provides your checks and what provides your work environment. So when we decrease administrative costs, services decrease. There is no two ways about it. So when services decrease, some people don't like those services decreased. We'll do our best to minimize that effect. But this comes from an expression from the faculty that we need to decrease administrative costs. And I'm not the one who initiated that discussion, but I believe it was a fair discussion. So we'll discuss the specifics of that offline. But you do have to understand that when we cut expenses, everything can't remain the same. And it's unrealistic to expect it to remain the same. You know, we're not sending faculty to the AAMC to decrease administrative expenses. Those faculty won't learn from the AAMC. There won't be new ideas that come back. There are effects of all cuts and expenses. And it's unrealistic to not expect there to be effects. And for someone to say, is it okay if it affects the guy or girl next to me, but not myself? IPE centers. So I believe in this strongly. We're going to be doing much greater interprofessional education with the nursing students, with the physician assistant students, with the pharmacy students, hopefully beginning in the very, very early part of medical school. Because the current and the future physicians are members of a medical team. And I believe strongly they may not be captain of that team. And the earlier students are exposed to that, the better healthcare leaders they're going to be. We got just about 4 more minutes.
Hi, if I can kind of rephrase my question. This is JJ Walbilic with Gynecologic Oncology. I've been part of some other institutions where I've seen the shift back and forth with the RVU model. I guess what I was getting at is that, you know, yes, we need to, most med schools do have some degree of an RVU incentive model, but I've seen that there can be a pendulum to and fro, like how much that's a focus, because there can be incentives that pull us away from the academic mission. So I guess my question is, are you monitoring that? And is that going to be reassessed? Because it seems like it's kind of like a dilemma. You have to sort of figure out how to balance it.
I know.
That's more
I
what I
know.
was getting at.
Yeah. You know, some places have come up with the academic RVU. I don't know if you've ever heard of that, where you provide RVUs for a grand rounds or for a small group session, and you put that into the equation. Our problem, or I should say our situation, is that we have a practice plan which is administratively and legally separate from the medical school. So the practice plan sets RVUs. Under this new system, the medical school pays faculty for clinical teaching, but only for clinical teaching and research, not for patient care. And that there's two paychecks, and one paycheck is for teaching and one paycheck is for clinical care. All I can say is we'll have to look at it carefully, and it ain't easy.
Cool, thank you.
For parking, you know, the DMC is the DMC, and the DMC will do what the DMC does. They do it without asking us, without consulting with us, or without even letting us know in advance. I don't think they're going to reverse the parking business. Again, I'm always going to tell you the truth. Their priority is not where students get to park. I think they do provide security guards to escort you to your parking spot late at night upon request. Okay, Neely, we can take that question offline. I don't think that's necessarily to give the information here, if that's okay. So I got about 1 more minute. Okay. Thank you all. Again, I think it's been a tough year, and you have my personal vote of thanks and express my appreciation for what you've done. I think the plan to go back to campus in a graduated fashion is going to be a readjustment for us all, and I understand that. And all part of that bargain is to make it smooth or smoother and safe, or if not safer. And we'll do that. And we'll hold the next town hall, I think, in 2 months. And I'm glad we had a lot of questions. I learned a lot, and we have a lot of issues to discuss. And we can do better. We should do better. And it's good to know about the things that we can and should do better. And I'll give you my word that I'll look at everyone carefully and do my best to always be better. Okay, thank you.